As physicians, we're charged by Hippocrates in our oath to first do no harm. However, when it comes to diagnostic testing and evaluating disease, many physicians are missing this very high mark. While there is a multiplicity of reasons for this behavior, from a lack of knowledge or ignorance to fear of litigation, many physicians routinely order unnecessary tests simply because, well, it's always been done that way. This week, an article in the Journal of the American Medical Association Internal Medicine examined the downstream effects of ordering unnecessary tests. The authors of the paper, which was entitled "The Prevalence and Cost of Care Cascades After Low-Value Preoperative Electrocardiogram Testing for Cardiac Surgery in Fee-for-Service Medicare Beneficiaries," found that in this particular case of preoperative ECG screening for cataract surgery, that the care cascade after these unnecessary tests can be quite costly. As a clinician, I really like this article. It tells us what many of us already know. Ordering indiscriminate, low-yield diagnostic tests often produces the need for other unnecessary tests and ultimately unnecessary procedures that can actually result in complications and patient harm. Not to mention all the unnecessary costs. You know, when I was a medical student and a resident at UVA and Duke, I can remember my mentors on general medicine asking me and my colleagues, "So why are you ordering this particular test on this patient?" If we could not provide a logical, well thought out reason for why the test was being ordered, and most importantly, how that test would change our management, the test was canceled. One particular attending that I feel very close to likened diagnostic testing to a fork in the road. If you order a test, the result should and must tell you whether or not to take the left side of the fork or the right side. If you're going to randomly choose either path, no matter what, the test is unnecessary and only tells you that the lab is open. Too often, doctors order tests out of fear or ignorance rather than based on science. It's time for doctors to stand up and be doctors. Use your training, your experience, and your clinical judgment in conjunction with very appropriate testing to decide when and how to test, treat, and perform procedures. Bayesian statistics tell us that ordering a diagnostic test, such as an EKG, for no good reason before cataract surgery will be very, very low yield. A good reason to order a test, according to Bayes, is when you have an intermediate pretest probability of a disease process. By that same line of Bayesian thought, if you have a low pretest probability, you don't need the test at all. If you have a high pretest probability, you should probably treat the disease, not test the patient. As you can probably tell by now, this is a pretty real hot button for me. As a cardiologist, I've seen far too many examples of unnecessary stress tests leading to false positives, leading to unnecessary heart catheterizations, and unfortunately, in some cases, negative outcomes due to complications of the heart catheterization. I've seen indiscriminate use of lab testing in emergency departments throughout the United States, where a patient, no matter what the history of physical exam or chief complaint, gets a troponin sent to the lab, even though the patient came in with no symptoms of coronary disease, no risk factors, and no related chief complaint. These, more often than not, come back indeterminate and create the need for an unnecessary cardiology consult and an unnecessary and very costly workup. So, in conclusion, as physician leaders, we must think before we test. Let's hearken back to Shakespeare and Hamlet's nunnery scene. To test or not to test? That is the question.